for each patient on an as-needed basis. And I think that was all I had planned.
So we have our pediatric orthopedic surgeon team. First, I'll introduce Dr. Melissa Esparza. She's a pediatric orthopedic surgeon at Phoenix Children's Hospital. She cares for patients with musculoskeletal injuries or conditions such as traumatic injuries, musculoskeletal infections, skeletal dysplasias, limb deformities, neuromuscular conditions, hip dysplasia and other hip conditions, clubfoot, and other foot and ankle deformities. She has a special interest in limb deformity and reconstruction, including limb lengthening. For Dr. Esparza, building strong relationships with patients and their families is key to providing the highest quality of care. Quote, "It is important to me to listen to families and understand their concerns, help them understand the diagnosis and treatment options, and come to a decision together about the best path forward for their child," she says. Dr. Esparza grew up in Tucson, Arizona, and earned her BA in Human Biology at Stanford University. She attended medical school at the University of California, San Francisco, and returned to Tucson for her orthopedic surgery residency at Banner University Medical Center, Tucson. She completed her pediatric orthopedic surgery fellowship at Texas Scottish Rite Hospital in Dallas, Texas. Dr. Esparza has an interest in global health and addressing health disparities locally and internationally, and has spent time in various parts of Latin America and Africa doing medical and public health related work. She's excited to be back in Arizona, serving its children and communities. All right, and we also have Dr. Mohan Belthur. He had his first exposure to orthopedics when he injured his elbow, leg, and foot as a child. Later, battling a serious illness during medical school taught him even more about difficulties patients can face and the value of receiving excellent health care. Those experiences inspire Dr. Belthur's compassionate and empathetic approach to patient care. As an orthopedic surgeon, he strives to improve the lives of children, adolescents, and young adults with musculoskeletal problems. Quote, "I love working with children and their families, being able to solve challenging problems and make a difference in their lives," Dr. Belthur says. Dr. Belthur is passionate about teaching, mentoring, and connecting, whether with patients and families or other health professionals. He's also involved in life-changing clinical research and global health. He works with nonprofit organizations focused on easing the burden of childhood musculoskeletal disorders in low and middle income countries. Sharing Phoenix Children's passion for providing hope, healing, and the best health care, he also appreciates being part of an organization that promotes diversity and inclusion. When he's not working, Dr. Belthur enjoys traveling with his family and visiting national parks and cultural heritage centers worldwide. He also enjoys running, hiking, biking, and yoga, and is training for his black belt in the South Korean martial arts of Tang Sudo. His interests also include reading about history, ancient Indian scriptures, leadership, and well-being. Thank you both so much for being here. I'll turn it over to you.
Great, thank you. All right, so yeah, thank you for the introduction and for having us here today. We're really excited to be here just talking to such a great group of people, both in person and virtually. I'll kind of be going through the talk, but Dr. Belthur will chime in kind of throughout. And we'll be talking about the orthopedic considerations in hypophosphatasia. So we'll give a little bit of an overview, talk about some of the musculoskeletal manifestations that we see of HPP, and then some of the treatments that we offer. So we work very closely together, but also with a lot of our other subspecialists. And for this presentation, we really tried to kind of keep the medical jargon as limited as possible. But I know that at least, in my experience, the patients and families that I've worked with kind of more rare diseases, I often feel like I'm learning as much from them as they are from me. And so hopefully this isn't too basic for everyone, but feel free to chime in and ask any questions as we go too.
So just one thing, do you want us to stop for questions in between, or do you want us to just complete our presentation and answer at the end? The second one.
Answer. Okay.
Thank you.
Okay, so you've already heard a lot about this already today, but just as a brief summary, the hypophosphatasia is caused by a lack of the enzyme alkaline phosphatase, which leads to poor bone mineralization. And as a result, we see soft bones, bones that are at increased risk of fractures or pseudo-fractures, limb deformities, including bowed legs or knock knees, and bone or muscle pain.
I would like to just add that when there is lack of this enzyme, it's substrates means the substances on which the enzyme acts, they are not kind of broken down, as a result of which the inorganic pyrophosphate, that's one of the building blocks for bone, that gets accumulated in the blood. And because of that, directly there is poor mineralization of the bone matrix. That is one thing. And also pyrophosphate is an important coenzyme for many other reactions, or what would say metabolic reactions in the body. For example, in the brain, respiratory system, and the other organ systems. So because of that, those enzymes also cannot work. So those are two mechanisms. And also because of that, there is accumulation of calcium and phosphate in the blood, and that can also cause like nephrocalcinosis. That means calcification of the kidney and other organs, for example, the joints, and that becomes more important in adults, can cause like chondrocalcinosis or degeneration, or predisposes to degeneration of the joint cartilage. So I just wanted to add that. Thank you.
So really there are a lot of different conditions that can cause similar types of symptoms and manifestations. We're not going to go through all of these different conditions in detail, but this is just to kind of show that when we have a patient that comes to us with some of these symptoms or some of these findings, there's a lot of different things, a lot of different underlying diagnoses that we consider. And so having, as it's been mentioned already multiple times today, having that multidisciplinary care to really come to the correct diagnosis and effectively treat symptoms and improve function is going to be really important.
I think I would like to add that sometimes one of the key things is diagnosis is not made in time, so there's a lot of delay in diagnosis because of lack of recognition of these symptoms, because they are variable. As you know, there are 6 types of hypophosphatasia. So, and the symptoms are a big spectrum. They range from being very mild to very severe. So especially on the milder end of the spectrum, sometimes you can miss the diagnosis. So that's where what the mind doesn't know, the eye cannot see. That's one of the codes. So hopefully, as we go through this presentation, if the mind knows, that it's more easy to recognize for the mind, because ultimately it's pattern recognition. And I would like to draw your attention to the schematic that Dr. Esparza has here, which differentiates between how a normal bone looks like and an abnormal bone with hypophosphatasia or rickets, one of the metabolic conditions, looks like. So you can see this is the long bone, and this end is called as the epiphysis. This is called as the growth plate area where the bone grows in length. This is called as the metaphysis, and this is called as the diaphysis. And this is just a cross-sectional view of how the bone looks like. And then you can see there is very few spaces or sort of cancellous areas, and then the surrounding area is pretty thick, as opposed to this abnormal bone here, where you can see there is widening of the physis. There's what we call some cupping, fraying of the metaphysis. In hypophosphatasia, you can also see some tongues of radiolucency, which you will see on the X-ray. And also, if you take a cross section, there's lots of these it's more porous. That means easily it can break, so less strength. And in between, the trabeculae are much more widely spaced and less thick. So that's what makes the bone more liable to fracture or deform. Okay, thank you.
And then just to go into that a little bit more and show some of the X-rays findings that we see in common musculoskeletal findings. These can vary pretty widely with the subtype of HPP, and I know Dr. Smith talked about this a little bit earlier, but the different subtypes have different manifestations, symptoms, and findings can vary significantly with the age of onset and the subtype. But some of the most common musculoskeletal findings that we see are osteomalacia, fractures and pseudofractures, limb deformities such as knock knees and bow legs, limb shortening, short stature, muscle or bone pain, muscle weakness, and gait abnormalities such as a waddling gait.
So in terms of the musculoskeletal system, for example, in the bones, what you can see here is, you can see there is a little bit of irregularity of the bone, like a moth-eaten appearance here. And also, if you can see here, the growth plate of the physis is kind of widened. There is cupping of the metaphysis here. Again, there is this radiolucent area here and here as well. And these changes are not that clear in the vertebrae, but you can have, if it's an extreme case, then you can have like a biconcave vertebrae, and then some pathologic fractures like wedge compression fractures, etc. In the ribs, you can see fractures, healing fractures. And then in the skull, you can sometimes see Wormian bones or craniosynostosis. I'm sure Dr. Bristol already talked about it. So, and the other things, if you take an orthopantogram of the teeth, you can see that, the root canals are wider, and those are some other manifestations. Okay.
And then we just have a few other x-rays that kind of show up close to some of those findings. So just going through these from left to right, this picture on the left shows a child with infantile HPP with some of the rib changes that Dr. Belthur was talking about in a flail chest. This second picture here shows, I think what Dr. Belthur had mentioned earlier, these metaphyseal tongues. So as he described in the bones, this is the epiphysis, that part of the bone that's kind of closest to the joint. This right here, this line here is the physis or the growth plate, and then this region here is the metaphysis. And so you can see in this x-ray that in the distal femur, so this is the knee joint, distal femur, the tibia, and the fibula, in all of these bones, you can see those metaphyseal tongues, those areas of radiolucency in the metaphysis here, here, and here. In this third x-ray here, you can see looser zones or pseudo fracture in adult HPP, and then another example of some stress fractures in an adult with HPP in the metatarsal bone, so here and here. And then I mentioned this before too, but you can have limb deformities, which the most common things that we see are either genu valgum, which is knock knees, or genu verum, which is bow legs. So here are both clinical pictures of genu valgum and an x-ray of genu valgum, and then of genu verum. Here's a clinical picture where you see that bowing of the legs, and then similarly on this x-ray you can see that this child's bones are bowed out to the side.
So what these deformities can cause is they can interfere with the weight transmission through the leg, and because of that, some parts of the joint, for example, in knock kneedness, the weight bearing can pass sort of outside the knee and then can load the outer part of the knee more than the inner part, and that can cause over time wear and tear on the outer part of the knee. And in genu verum, the weight-bearing axis can cause medial or inner on the inner part of the knee, and that can cause wearing out of the inner compartment of the knee, and that can again cause like wear and tear arthritis, or what we call secondary osteoarthritis of the joints.
And then the spine can also be involved as well. So scoliosis is one of the common spine conditions that we can see in HPP. And then there have been several case reports of a rare finding, but that there can be calcification of the spinal ligaments and spinal cord compression in patients taking aspartame alpha. Again, it's been very rarely reported, but just something we wanted to mention because we've seen that a couple of times.
So we talked about the higher calcium level in the blood. So when they start taking the medication and it starts getting deposited in different parts of the body, for example, around the ligaments, in the cartilage, in the spine ligaments, in the kidneys, that can cause things like nephrocalcinosis or calcification of the kidney, or chondrocalcinosis or calcification of the joint cartilage, or in the spinal ligaments, and that can cause narrowing of the canal where the spinal cord goes through, and that can cause or manifest as weakness of the legs or arms, numbness, or even if it's severe, can cause like bladder bubble sort of issues as well. So that's how it would manifest. It's not common, but it's been reported.
All right, kind of moving on to the next section. In orthopedics, really we have a really big focus on quality of life and trying to improve patients' quality of life. So we found a couple of articles talking about the burden disease and quality of life in pediatric patients with HPP. So these articles focus specifically on pediatric patients, but there are others, and I think similar for adults with HPP as well. But I have a quick slide on each of these just to kind of go through some of the findings they had. So this first one by Rush et al. Was a study on the burden of disease of children with HPP. So they had 59 children who completed 2 surveys, as well as their caregivers who completed the surveys, and found that the most common health issues were pain, muscle weakness, difficulty gaining weight, and delayed walking. And these 2 graphs on the side just show that some of the results as well, that they looked at both physical and mental scores for quality of life, and found that it was really that physical realm that was the most affected. And then as far as what were some of the main things that patients had trouble or difficulty with, were just more moderate active activities, bending and lifting, daily activities, and then this looked at both daily activities from both a physical or mental emotional standpoint. But the overall summary of this was just that HPP can have a very substantial impact on health-related quality of life, particularly in the physical functioning realm. And so I think studies of these are important just to kind of quantify that, so that going forward we can have resources look at and go to finding ways to optimize patients' quality of life.
I think the other important issue is, if we have good measures of quality of life and we are using it in clinical practice, it's good to know where they are and how the treatment is impacting them, and understand what the long-term outcome and impact of care is.
And then this next study was a little bit similar. It was a survey study, so there were 30 children with HPP. And this one I think was a little unique from the last one in that it showed that there were quite a few behavioral changes as well. So some of those most common behavioral changes included sleep disturbance and symptoms of ADHD. And what this diagram on the side shows is basically looking at some of those symptoms. So pain interference, anxiety, depression, aggression, attention problems, hyperactivity, and adaptive functions, that all of these things really affected both the physical quality of life and psychosocial quality of life. And so this graph is a little bit confusing, but you can see in the red here that this is basically just showing that all of these factors here influenced that physical and psychosocial quality of life of these patients. So just important to pay attention to some of these behavioral and psychosocial issues as well.
And then the other thing in my reading I came across was that things that impact life in the first year of life is respiratory function or respiratory insufficiency, and that's because of combination of significant muscle weakness, tracheomalacia. Those are the 2 issues. And then later on, cranial synostosis, I'm sure Dr. Bristol talked about it, that can cause increased intracranial pressure and that thing. And then later on, like in childhood and adolescence, adult life, is more of musculoskeletal aspects like bone pain, fractures, deformities, etc. Those are the things.
Okay, so moving on to treatment. Again, we're orthopedic surgeons, so there's a lot that we operate on, but we always try to find non-operative ways too that we can increase patients' quality of life, decrease their symptoms. And so we work very closely with our orthotists to find methods such as bracing that might help, and work with our physical therapists, our occupational therapists as well, to really try to find ways to maximize patients' function, decrease their pain in a way that is non-invasive without surgery. And so here are just a couple of pictures of kids that have braces that are helping them with their gait, and can help in various ways depending on what their symptoms are.
I think the other, like they say, it takes a few people or a whole village sometimes in the more severe patients to take care of these children. I would say that, because I think they lose their teeth, that may impact their ability to eat and nutrition. So, I mean, that's very important. So having a nutritionist or access to a nutritionist is important. And then having neurosurgeon on board to help with, looking at the craniosynostosis issues, and then maybe help scoliosis. Sometimes we operate at the same time, decompressing the spine as well as working on the spine. And then the endocrinologist comes into picture and, diagnosis. Like sometimes we see x-rays that look like rickets, and then I'm immediately emailing Dr. Smith, say, can we get this patient in quickly into your clinic? And then, so they're important. And then we also probably sometimes need social workers, because a lot of these patients have sometimes challenging social circumstances. So they also are very important. We also need child life specialists, especially if they have like behavioral issues and other things that can impact us being able to take care of them. So all these people are very important in being able to care for the children.
All right, and we'll just talk a little bit about operative care as well. So there are a wide variety of procedures that patients might need with HPP. And so these are very broad categories, but guided growth just describes an approach that we use to help with limb deformities. And this is something that we can really only do when a child is still growing. So there are multiple different terms for this: guided growth modulation. The medical term for the procedure is called hemiepiphysiodesis or physeal tethering. So the physis is the medical term for the growth plate. And so basically what this involves is tethering one side of the growth plate with a metal plate and screws. So you can see we call these 8 plates because they're sort of shaped like an 8. And so this is just a titanium plate that we put on one side of the growth plate and put a screw on either side of that growth plate. And so these are 2 different examples. We'll start with the bow legs, or genubarum. So in this x-ray, you can see that the legs are bowed. And so we put one of these 8 plates on the outside or the lateral part of the tibia in this case. And by doing that, that stops the growth plate from growing on that lateral side. So if we stop the growth here, allow this medial or inside part of the bone to continue to grow, then over time, that leg actually straightens out. And so you can see the before x-ray here and the after x-ray here, where the legs are now straight in that same patient. And then once the legs are straight, we actually take the 8 plate, the metal plate out. This x-ray on the left here kind of shows the opposite. So this is a patient with not as severe as we saw in the previous x-rays or that we see here, but this patient has mild genu valgum or knock knees. And so in this case, we tether that inside part of the growth plate and allow that outside part to still grow, and over time, those legs straighten out. So it's a very powerful tool in a patient that is still growing, and something that is pretty minimally invasive compared to some of the other types of procedures that we sometimes have to do.
Yeah, so as compared to osteotomies, which people were using, and sometimes we still do, especially in the adolescent children where they have less than 2 years of growth, or in the adults where they don't have any growth. So, so this is less invasive, as she said, and very powerful, but it takes time. So it's a method, it guides the patient's own growth. So it harnesses their own growth and just kind of puts a hand around them so that they grow in the correct way. While the osteotomy is more invasive, bigger incisions, more blood loss, and it's immediately it corrects it. So use it for more severe deformities in people who have less growth or already completed growth, and also fewer complications. So that's why it's more attractive.
And then Dr. Belthur mentioned the osteotomy, so we'll go into a little bit more about that too. Basically what an osteotomy is just cutting the bone. So as compared to the guided growth with the 8 plates where we can tether one side of the growth plate, for these patients we actually have to cut the bone in order to straighten it and correct the deformity. And then with the osteotomy, there are various different ways to provide fixation or stability to the bone to let it heal, prevent future fractures, and correct the alignment. So one of those ways one of the methods for fixation that we use are external fixers, which you can see a picture of here. Sometimes we call them frames. They're circular metal rings basically that will go around the extremity, and you can have multiple rings, at a minimum 2, sometimes 3, and then struts in between each of those rings. And with these struts, you can make little adjustments of them over time to slowly correct a deformity over time. And then once the deformity is corrected, you allow it to heal, and it heals in a straighter position. These can also be used for lengthening bones as well. There are also internal methods for fixation, and also I have another more diagrammatic picture on the next slide. But basically with these, this is just one type of implant where the bone is cut, and you can see in this x-ray here that there were multiple osteotomies that were made to go from this bowed appearance to straighten it out and put a metal rod down the middle of the bone. So that's an intramedullary nail.
So sometimes because the deformities, it's a microfracture and the bone heals in that position, they usually end up with an S-shaped or a C-shaped deformity, as shown kind of here in this picture on the left side on the X-ray. So so you may have to do one or more osteotomies, where you can see here where the bone is cut or the cursor is pointing to. And then because you can only put a straight rod in a straight bone. So if the bone is bent, then you have to cut the bone in one or more places to make it straight before you can put the straight rod in. Okay, so that's what this shows.
And that's, that's what this diagram shows. So these are a couple different steps, just kind of shown in cartoon form. So this would be the first step where we actually put a metal rod or a wire down right to the spot where the bone starts to bend. And then in order to get that down the rest of the bone, you actually have to cut the bone in that area. Once you cut it or do your osteotomy, then you can straighten it out and advance that K-wire and the rod further. If it's a more severe deformity, then sometimes you have to make multiple osteotomies in order to straighten out the bone completely. So this kind of shows that progression of getting the rod down to the curved part of the bone, cutting it, straightening it out, and then doing that again farther down in the bone to your final outcome here of having a straight bone with a metal rod down the middle of it.
The other important thing is, because as you can see, these are children that still have growth. So it's important that the rod allows for growth. Okay. So this is actually what we call as a telescoping intramedullary rod. That means there's 2 rods in it, one inside the other. So there is an inside, like a male part that you can see here. And then there is an external, you can probably see it here. You can see the pictures here and here. There is some growth happening where the female kind of grows out with growth because they are engaged in the epiphysis, and as the epiphysis grows away, they're going to pull that part away from each other so that the nails can telescope. And that way you don't have to go in and keep revising it, and you can put it in safely, and then it'll give you, based on how much overlap there is, easily 4 to 5 years before you have to go back and revise it again. So, and it acts like an internal splint. That way, patient or the child can participate in various activities safely without having a lot of pain, and also without the need for having a lot of external support. And also because the leg is straight and more stable, they can do various things that I weren't able to do before. So it improves their quality of life.
And then for adults, because adults are not growing anymore, there are still similar methods for stabilizing a bone. So especially in cases of fractures or pseudo-fractures, and you can see here, we have circled a couple places where there are fractures in the bone, and that can cause pain. It can cause increased risk for that fracturing further. And so we can do the same, not exactly the same method, but basically the same idea of putting a metal rod that supports the bone internally and really bears the weight of that bone in order to stabilize and allow those fractures to heal.
I think the other important principle is, in general, intramedullary devices, those inside the bone, are more stable and more forgiving in terms of having fewer complications, as opposed to having an extramedullary, that means outside the bone, like a plate or screw, because the bone is weak. So if you put a plate, which is pretty rigid, it can cause a stress raiser below the plate, and sometimes they can then fracture below the plate. So usually we try and avoid what we call a load bearing implant. We would want to use a more load sharing implant, like a nail, as opposed to a plate and screw, unless there's no other option. So that's one of the important principles. And obviously, before we end that, I don't know if is Dr. McClendon talking about spine? No, okay. Anyway, so we also talked about scoliosis. So in those, some patients, I think only about maybe 1 out of 6 or 1 out of 7 patients with severe HPP may have scoliosis. And if it becomes severe, that means we usually grade it into mild, moderate, and severe scoliosis. If it's mild, it's less than 25 degrees. Moderate would be 25 to 50. And if it crosses 50 and starts getting more than that, then it starts getting into the severe category. There could also be kyphosis. So scoliosis means curvature as you look at the patient from the front. And then kyphosis means as you look at them from the side. That's kyphosis, or a round back deformity. Sometimes there may be a combination. And in those patients who have a severe, like a spine curvature in 1 or more planes, that's affecting their function or body image, or their ability to sit comfortably, and impacting their quality of life. We usually start off with observation, and if there is progression, then we start using a brace in the child that's growing, and if this curve is small. If that's not, be able to hold it in, sort of treat the condition, then sometimes we may go to like instrumentation of the spine. So we use like screws in the spine at each vertebral level that's in the curvature, and also rods. That's called posterior spinal instrumentation. So sometimes we have to do that. Okay. So.
Yeah. Well, that's most of what we wanted to talk about today. So just in summary, there are different types of HPP that have a large variation in symptoms. Some of the main MSK abnormalities or musculoskeletal abnormalities that we see include knock knees, bowing of the legs, shortened legs or leg length discrepancy, a waddling gait, and muscle weakness. HPP can substantially impact quality of life. And orthopedic management includes both non-operative and operative treatments with the goal of optimizing quality of life. And really multidisciplinary is key. You've heard that over and over again today, and so that's something that we're really proud of here at PCH that we're able to do.
Thank you for your attention, and we are happy to answer any questions you may have.
We have our pediatric dentist, Dr. Charlie Clark. Originally from Seattle, Dr. Charlie Clark received his undergraduate degree with the University of Washington. During this time, he spent a year living abroad, studying at the University of Granada in southern Spain. He graduated from the Arizona School of Dentistry and Oral Health in 2007, and then completed his residency in pediatric dentistry at the Children's Hospital of Wisconsin. Dr. Clark is certified by the American Board of Pediatric Dentistry. He currently serves on the board of directors for several local organizations. His passion for travel and service takes him to Guatemala every year to operate a dental clinic with Canadian-based Dentistry for All. When he is not busy working, Dr. Clark enjoys spending time with his family, grilling out back, and taking his 4-year-old yellow lab Dex on runs. Thank you so much. Dr. Clark, take it over.
Thank you. All right. Let's see. Where do we go to our next slide? Perfect. So as mentioned in the introduction, my name is Charlie Clark. I'm a pediatric dentist here in the Phoenix area. You guys already got a great summary of my educational background. Part of that, I think, is helpful in understanding how I got involved in hypophosphatasia. And so in our education to become a pediatric dentist, we go through 4 years of undergrad and then 4 years of dental school. Undergrad, all your basic sciences, then dental school, you learn how to diagnose, restore, prevent, all the big things about dentistry, and you